Now, I hope I remember.
Can everyone see that okay?
I can see it.
Perfect.
Okay. And you guys can hear me okay if I talk in this level of voice? Okay.
Yes.
I hope I remember all the details. If not, I'll pull up her chart. And so this, I would appreciate feedback on this lady. She is a 66-year-old Caucasian female. I've been treating her for type 2 diabetes for over 10 years. She's been on insulin for over 4 years, and she's been really previously well controlled. I didn't dig back through her chart, but definitely she's been below 8, and I think probably between 7 and 7.5 until quite recently. Her A1C in recently was 8.2, and then in February it was 8.6. It's interesting for me to be presenting a case where I'm asking for help with somebody who has an A1C in the 8s. Usually they're 10, 11, 12. So in some ways that's nice for me. She does test at home, and when I talked to her at her most recent visit, her fastings had been below 120, but she had not had any hypoglycemia. I'll get to her medications in a minute. The other part of the case is that she has hypertriglyceridemia and hypercholesterolemia. She's currently on a max dose of atorvastatin, and she's on Tricor 48 milligrams. I'll get to her numbers in a minute. She doesn't miss doses of insulin. She's fairly careful about diet. I think she gets regular exercise, or she tries to. She lives with, interestingly, she lives with her husband who has type 2 diabetes. He has very poor control. He doesn't follow a diet. She also cares for her disabled adult brother. She has 2 grown daughters who are not at home, and she's a homemaker. She has hypertension. She has proteinuria. I don't remember too much about the story actually in the proteinuria, but her renal function is normal. She has a normal BMI. At her most recent visit, her systolic blood pressure was a little bit elevated, 146/70. So my concerns are here in the labs. Her most recent total cholesterol was 199. Her triglycerides are 338. And her LDL is 104, HDL 38. And then I told you her A1C was 8.2. I had started her, I'm not sure in what month, on Tricor because her triglycerides were 448, and I thought that was close enough to 500 to warrant treatment. In the past year, her LDL has been below 70, and so this time it was 104, and that's one of my questions, like, should I be pushing to get it below 70, or can I recheck it and see if it gets below 70 again? Her renal function is listed there. Her recent BU and creatinine were 21 and 1.05 respectively. The creatinine was within normal limits. The GFR was slightly down, 55, which I think was different for her. These are her meds. So she does take, let's see, a baby aspirin, atorvastatin 80, as I mentioned, the fenofibrate 48. And then can you scroll down, Elizabeth, and let's see where her, she's on Jardiance, 10 milligrams. She's on Levemir, 27 units twice a day. And as I mentioned earlier, she does not miss doses. Levemir is what's covered by her insurance. Metformin 1,000 milligrams twice a day, and also 500 milligrams in the morning, I think she takes that. So she's on a total of 2,500 of metformin. She's on Quinapil 20, Quinapril 20. And then let's scroll down. So I've actually, I think, 3 questions about this. At her last visit, before I decided to present here, I thought, well, I'll just, her fastings are normal. Let me have her check her postprandials and see if maybe I should add in a pre-meal short acting to see if, you know, she's having spikes after she eats. But any other suggestions I would appreciate. Her lipids, I guess I sort of feel like I should just wait and recheck her LDL again. But any thoughts on that would be helpful. It sounds risky to me to add Zetia to a regimen that already includes a statin and a fibrate, but I wanted to see if that's ever okay to do to try to drive an LDL lower. And should she be on 81 milligrams of aspirin? I am worried that I'm behind the times. I recently attended a CME where they said it's no longer recommended to give 81 milligrams of aspirin as primary prevention. She doesn't have any cardiovascular or microvascular complications unless this is some early, I don't know about that proteinuria. I put that in there, but I'm fuzzy on that history. But at any rate, so that's the story and those are my questions.
Thank you. So in looking at the case, I think a couple of things that I had questions on. When we use metformin, we typically drive it up to a maximum dose of 2,000 milligrams in a day. So I don't know how much that extra 500 is helping her. And with her renal function, I would probably get rid of that and just keep her on the 5,000, or I'm sorry, 5,000, the 2,000, the 1,000 twice a day. I think it's great you have her on Jardiance. Was that recently started or has she been on that for a while?
I will look that up as we're talking.
Okay, because one of your other options could be increasing that as long as she's tolerating it, not having frequent urinary tract infections or vaginal yeast infections. She could tolerate a dose increase to the max of 25, and based on this renal function, it would be fine to do that too. I definitely agree with checking the postprandials too, just to see where she's having that spike that's leading to her A1C being higher, and maybe start there. That would also help her lipids too, particularly her triglyceride, maybe not so much for the LDL, but the triglycerides will probably improve with treatment of the blood sugars. Now they may still be higher. And if that's the case, I like your question about the Zetia plus the Tricor plus statin. Probably the first thing that I would do would be to go up on her Tricor. And I don't know if you need to do it now. I think if you improve her blood sugars, that will lower those triglycerides some. And then if you still need that extra push, you could go up to the maximum dose. I think it's 157, 148, I think, of the fenofibrate, and that one plus the statin should be fine. And then later on, you could add Zetia if you need to for that extra push for the LDL and total cholesterol.
Okay, awesome. By the way, she has been on Jardiance for quite a while. So
okay,
yeah, I don't know why I didn't think of increasing that. I will do that. And she hasn't seemed to have any, she has not seemed to have any adverse, so no UTIs.
Okay, good. Yeah, I think that would be a good place to start. And you could still have her checks, even when you go up on the dose, you could still have her check some of those 2-hour postprandials just to make sure that there's nowhere we're missing during the day where she's, climbing after dinner. And even though the sugars in the morning look good, it's those highs we might be missing that are making the A1C look a little bit higher.
Yeah.
So I would still have her do that. And sometimes I'll have people vary it up. They don't like to check their blood sugars, 5 times a day, which I totally get that. But
right.
You could just have her switch it up, a couple of times at lunch, check before and 2 hours after lunch, and then maybe check it before and after dinner too.
Okay. Okay. That's good.
She doesn't have any familial hypertriglyceridemia history, does she? It doesn't look like hers are high at that high that I would expect that, but.
I don't think I've ever asked. I can ask her that. I think that 448 was the highest I've ever seen them.
Okay. Because I know that her BMI is really, I mean, she's at a good weight right now, but if she ever needs add-on therapy for her diabetes, you could always consider a GLP-1 agonist like Ozempic or Trulicity, something like that.
Okay, good.
And then as far as I think if I didn't touch on this, I will. I think it's fine to give the statin plus Zetia plus Tricor, but maybe try the blood sugars first and then repeat her lipids again before adding that in there.
Yep.
I don't remember exactly how much the Zetia will add. I think it's like 10 or 12 points lowering of cholesterol, but I'd have to look it up. So I think you're going to get the most bang for your buck with the Tricor, the statin, and then the Jardian's helping lower the blood sugars.
Okay, good. And like I said, that was a little bit of an anomaly for her.
Sure.
Her LDL to be over 100. So, okay, that's helpful. And then what about the baby aspirin?
So I know that a few years back, that was a recommendation. Now the recommendation is really, it's mainly secondary prevention. So, or if you have somebody that's a diabetic that's really high risk for cardiovascular disease, you can have a risk versus benefit discussion. I mean, if they're a high risk for bleeding, maybe steer clear of it. If they're not, and they would benefit from it, like significant family history, you could add it. But I think at this point, it's more for secondary. It's like a higher emphasis on secondary prevention at this point in time.
Okay. And diabetes isn't considered a cardiac equivalent.
It is, and I think this is from ADA guidelines that say, if somebody if you have a diabetic that has a high risk for cardiovascular disease, or they've had cardiovascular disease before, you can have that risk versus benefit discussion with her, but I don't think she absolutely has to be on it based off of the case presentation.
Okay, very helpful. Thank you very much.
You're welcome. Do you have anything to add?
Yeah, based on the picture, the high LDL and the triglycerides, looks like it's probably familial mixed hyperlipidemia. So especially if she's on like a lot of, excess of statin. So how's, based on the recommendations, medications, but how about her diet?
She says that her diet is healthy. Now, she lives with this guy who, I forgot what she told me he eats last time, but it was, Danishes or something. I believe her because she's fairly serious. Now, I haven't done a detailed history, but we've talked about it for many years about what is healthy and what is not. And she's one of my people who, whenever she does give me more details, it sounds like she's eating what I would say is avoiding baked goods and eating healthy fats.
Yeah, so whatever, I think the medication recommendations Jen outlined, I think it's pretty adequate.
Okay, great.
Thank you so very much. Does anybody else have any questions for Jennifer? Hi, Dr. G, I see that you unmuted. Go ahead.
Yeah, I was just going to add, I think Dr. Turner's suggestion about a GLP receptor agonist is a great suggestion because even if she doesn't have weight to lose, there are added benefits for GLP-1 receptor agonists, including improvement in renal function also. Not just the SGLT2s help with renal function, but also the GLP-1 class. And I try to get people on as little amount of insulin as possible because we know, insulin causes fluid retention, weight gain. And so if she would tolerate that, she has no history of pancreatitis, I think that'd be a great option. As far as her aspirin goes, I think a really good tool is the American Cardiovascular Risk Calculator stratification and plugging in her risk. I do agree with Dr. Turner in optimizing her therapy because her risk, the one piece of data I didn't have to import into that risk calculator was her total cholesterol. But I imported her blood pressure, her HDL, and everything else that you had given. And that spits out a risk of about 31.5. So that's a pretty elevated risk. And I think that really is helpful in dosing aspirin, but also dosing your intensity of statin. That's a great tool to use.
I use that tool all the time when I'm looking at whether to start somebody on a statin, but I had never thought to use it just to calculate her cardiovascular risk and think about the aspirin. So that's very helpful.
Yeah, I think as a general rule, just in diabetic patients that are greater than age 40, most should just automatically be on statin therapy.
Thank you so much.
Sorry. Incidentally, in this day and age, I'll make a note that she is steadfastly refusing COVID vaccination. So in spite of me counseling her about her individual risk and all the other community risks. So I'm hopeful that she won't get COVID, but that would certainly make a lot of this a moot point if she got that and got very sick. At any rate.
I saw that Hugh,
Very
that you
sad.
unmuted as well.
Yeah, I just had a question for the group, I guess. Given the patient's cardiac risk and her elevated triglycerides, if you'd consider switching from the Tricor to Vascepa, and that would also help eliminate the risk of increased myalgias if you decide to add Zetia in the future. So you kind of prevent that risk of starting all three of those medications and you get the added cardiac benefit. I did see she was on fish oil. I'm assuming that's just over-the-counter fish oil, but I was wondering if you guys think that may be an option.
Yeah, that's definitely a good idea. So if they have familial hypertriglyceridemia, oftentimes I'll add it to the Tricor. I think for this patient, she could even stay maybe on the Tricor and add on the Vascepa in addition if she needs it. Sometimes what we find, and the reason I say control the blood sugars first for your patient, and it's not that they're wildly uncontrolled. Her A1C is 8.2, so she seems to be doing okay. If you have an insulin deficiency, so somebody's sugars are really uncontrolled, you really don't have the ability to break down triglycerides. So hopefully they'll improve with some improved control in the blood sugars, but I definitely think what Hugh had mentioned is a good option. So, possibly keeping that on the back burner. If her next set of triglycerides aren't well controlled, you could go up on the Tricor first. Depending on how bad they are, you could go up on Tricor and try to add in the Vascepa. Isn't there another one, Dr. Quinn? Isn't there another, it's like Vascepa and I can't think of the name.
There's a Lovasa, which
Yes,
does
okay.
not have the cardiac benefit data. And then there is also a new generic equivalent of Vascepa, but that technically has not been given the FDA indication for cardiovascular risk reduction. It's only been indicated for triglyceride treatment.
Okay. I didn't realize that was out, so that's good.
So I'm familiar with Lovasa. That's a fish oil, right? But the other one, can you spell it for me? Vascepa?
Yep, VASCEPA, and it's just it's EPA instead of EPA and DHA mixed. So
Okay, interesting. I didn't know about that.
yep. If you want to look up the studies, and they were called REDUCE-IT, REDUCEIT, and that's the cardiovascular benefit studies for it.
Awesome, thank you.
Excellent. Thank you guys so much. Such great comments and discussion. Is there anything else before we move to the didactic portion of the presentation?
I'm so sorry, Dr. Turner. I have to hop off. I'm on call and I'm getting paged from HEMONC. I will try to rejoin. I'm sorry.
No, that's okay. I appreciate you jumping
I can
on.
watch it.
I'll try to hop back on if possible.
Okay. Thank you.
Bye, Dr. G. Thank you. All right, I'll go ahead and share my screen for you. Just give me one moment, please. Can everyone see that okay?
Yes, thank you.
Perfect. Thank you. Alrighty, and I will just control if you want to tell me next slide at any point, let me know.
Okay, we can go ahead and go to the next one now. So I'll be talking about hyperparathyroidism today. This is kind of just a summary slide. So there's 3 different types of hyperparathyroidism. So there's primary, where you have excessive secretion of parathyroid hormone from either one or more of the parathyroid glands. Remember, the parathyroid glands are located in the neck, kind of hugging up right behind the thyroid gland. There's 4 of them, and they're about the size in a normal state of the grain of a grain of rice. So 4 little tiny grains of rice in the neck. If one of these or more of them start overacting and stop responding to feedback, that can cause the serum calcium to rise. So that would be primary. Secondary, I remember just by, the name itself. So secondary is a rise in parathyroid hormone level, secondary to another problem, whether it be chronic kidney disease, vitamin D deficiency, or malabsorption of calcium. Oftentimes we see that in patients that have had bariatric surgery, and so they're not absorbing the calcium from their diet very well or effectively. So the serum calcium will look mid-range, normal, to sometimes even at the lower end of a normal range. And then tertiary hyperparathyroidism, I'm not really going to touch so much on that. That's really where the parathyroid hormone level has been elevated for so long due to longstanding secondary hyperparathyroidism that you kind of get this bulky, all 4 of the glands start overworking and stop responding to the feedback mechanism. So you'll get a serum calcium level that's elevated and a phosphorus level that's elevated. And usually the only time I've ever seen that has been in patients with advanced chronic kidney disease or even the end-stage renal disease patients. Next slide, please. Thank you. So one of the big points that I wanted to make today is that, I know patients have access to the internet now, which can be a good thing and a bad thing sometimes. We don't recommend ordering PTH just with a routine set of labs. Sometimes people will tell you, could this be my parathyroid gland? Well, if their calcium's not elevated, you're really not going to have any symptoms. So we don't recommend ordering that just as a routine lab. Next slide, please. So, I know oftentimes the concern is raised when someone has an elevated calcium on their routine labs. So that's oftentimes the referrals that we're getting, it's based on that. The PTH was appropriately ordered after an elevated calcium, and that's the labs that we have. Next slide, please. So the first step, if you have a calcium that is high, would be to, and this is exactly what we do in our clinic, is we confirm that the calcium is actually truly elevated. And how we do that is we'll order an albumin. So what I would suggest is, if you have a patient that you're just ordering a routine basic metabolic panel on that has, say, diabetes, and that's why you're ordering it, and the calcium comes back high, I would recommend repeating a calcium and also getting an albumin at the same time. So if the albumin is really high, it will correct the calcium lower than what it actually is. On the flip side to that, if you have a low albumin, then if you get that serum calcium of 10.6, it's actually going to be higher than that based off of the low albumin that they have. So we recommend repeating it. Sometimes what I'll see is that, they've had a high calcium and then an albumin is added on, 3 days later to a separate lab, but we don't know what the calcium was that same day. So I always recommend that you get the albumin and the calcium on the same day if you have a first one that was elevated. Next slide, please. So, after you do confirm that there's an elevated calcium, the next step would be to obtain a parathyroid hormone level or a PTH. And I mentioned on the last slide, getting an albumin and a repeat calcium. If you have a first calcium that's high, you can just go ahead and repeat, when you go to repeat the calcium and also get an albumin, you can just go ahead and get a parathyroid hormone level at the same time. And then we would also recommend, checking kidney function, so a creatinine, and then a phosphorus and a 25 hydroxy vitamin D level is what we would recommend. I know there's a few different vitamin D levels that you can obtain, calcitriol being one, but this is the one that you would remember is the 25 hydroxy vitamin D. And the reason that you're going to be doing that is to actually confirm, that you have a high calcium, and then you're checking a vitamin D to make sure they don't have vitamin D toxicity. And that's why Sometimes the calcium will just be a fluke. You know, you have a calcium that's high on one set of labs and the next day it looks fine and the PTH is high. Well, if your vitamin D is really low, you'll know what the cause of that higher PTH is. So if you have a PTH, I may have already said this, I kind of looked off the slide for a few minutes there. If the PTH is either normal or high and the setting of a high corrected serum calcium, you know right off the bat, this is a PTH-mediated hypercalcemia. And then at that point, we would recommend referring to us for further evaluation. And even when you're first evaluating a patient, that's after you confirm, I don't know what everyone uses. We use UpToDate here, but even when you're looking at hypercalcemia, first step is to confirm that it's actually high. The second step is it PTH mediated or non-PTH mediated? Once you confirm that it's PTH mediated, so your calcium's elevated and your parathyroid hormone level is either high or inappropriately normal, remember, because if the calcium in the blood is high, in a normal situation, that parathyroid hormone level should be low. And if it's not, you know that's inappropriately normal. There's a few different causes for that or of that. Primary hyperparathyroidism being one, also tertiary. And then there's something called familial hypocalciuric hypercalcemia. So this is a genetic problem where it's basically you have a different set point or a higher set point for calcium. So these folks will have high parathyroid hormone level, their serum calcium may be in the 11 range, but they have absolutely no problems. It runs in the family. They don't develop kidney stones. They don't develop osteoporosis as a result of this. It's just they have a higher set point than everyone else. If they've had previously normal serum calciums in the past, then you can pretty much assure yourself that that's not, that they don't have FHH, but it's definitely necessary to rule it out before you proceed with the workup or even surgery for primary hyperparathyroidism. Next slide, please. So when we're evaluating someone for primary hyperparathyroidism, our diagnosis is based on labs. I know I'll talk about some imaging here in a little bit, but even if you have imaging, I know some primary care providers will feel comfortable ordering imaging. And if so, if the imaging's negative, doesn't mean they don't have primary hyperparathyroidism. That's a biochemical diagnosis. So we oftentimes will repeat labs here. I shouldn't say often, we almost always repeat labs here just to make sure that elevated PTH wasn't just a one-time thing. So we'll do that, and we'll also order calcium, albumin, renal function. I know I mentioned this on the last slide, if the patient has had a prior serum calcium that wasn't elevated, I actually saw someone this morning with primary hyperparathyroidism, and they had labs back from 2012 that showed a perfectly normal serum calcium. So sometime in between 2012 and 2018, she developed this primary hyperparathyroidism. So I can feel confident with saying that that FHH, that familial problem, is unlikely. If they don't have any prior available calcium, we'll oftentimes repeat labs and we'll do urine testing. So really the way, if you have a patient that you're not sure, do they have primary hyperparathyroidism or familial, the FHH that I talked about, the way you distinguish is with a 24-hour urine collection, which we usually do here. I wouldn't expect that the patient has this before they're transferred here. I just like to talk to everyone about it, just so if you see that we've done this on your patients, you know why. Next slide, please. So when we do a 24-hour urine collection, we do both a 24-hour urine calcium and a creatinine. And here's why. So if you get a patient and you see their calcium is low, but their creatinine in the specimen is also low, that's an inadequate specimen. So you really can't say it's FHH or primary hyperparathyroidism based off of that. So you want to make sure that's an adequate specimen. Sometimes people will over collect their urine or under collect it. And really that 24-hour urine creatinine will help you out determining whether it's a good specimen or not. Before I do this, and I've had to learn the hard way because sometimes people will get started on an hydrochlorothiazide in between the time that I order the urine and they complete it, and then I have to have them repeat it. So I always ask the patient, have you, is your vitamin D replete? You're not taking any SGLT2 inhibitors like Jardiance, Invokana, hydrochlorothiazide or lithium before I do the urine collection. If they are on those agents, I'll usually stop them for a couple weeks and then have the patient do their urine. And they're fine to go back on those agents, but they can falsely, thiazides retain calcium. So your urine calcium may look falsely low if they're on hydrochlorothiazide. SGLT2 inhibitors, those can make the calcium look a little bit higher if I remember right. I had a patient that was on that recently and I had to have him repeat it. So it's always good to ask them and make sure you do a med rec before having them do that test. Next slide, please. So when the urinary calcium is low, that's kind of that familial hypocalciuric hypercalcemia. So again, that set point problem where it's not really a problem, but they're born with just a higher set point. They don't excrete as much calcium in the urine. It's typically under 100 milligrams in a 24-hour period. Oftentimes we'll calculate a FECA. I know when you're working up AKIs, you can calculate a phe-urea or a FENA, so the fractional excretion of sodium. So this is a fractional excretion of calcium. And typically, if it's less than 0.01, that's more consistent with FHH. So they would need additional testing at that point. Again, this is something we are happy to deal with. I'm just kind of talking through it for everyone. If a urinary calcium isn't low, that will oftentimes rule in primary hyperparathyroidism. And then, when we have that and we can rule it in, at that point, our next step is determining whether the patient meets criteria to be sent for surgery or not, because a lot of times they don't. Next slide, please. So these are, if someone is symptomatic, they have a high calcium, it's not meeting these criteria, which I'll kind of go through here in a few minutes. If somebody's symptomatic from their calcium being 10.8, then they automatically, you can send them to surgery. If they're having symptoms, you can send them to a surgeon for an evaluation. They may not be a good surgical candidate. It's really taking the whole picture into consideration. But as far as patients that are asymptomatic, which are, I feel, the majority of people that we're seeing, they just happen to get, hypercalcemia picked up on their labs, and then they're further evaluated. It looks like they have asymptomatic primary hyperparathyroidism. These are the surgical criteria that we use. So if they're under 50, they automatically meet the criteria. And just kind of as a disclaimer, any of these criteria, you don't have to meet all of them. Any one of them would, say that they've met surgical criteria. If their serum calcium's 1 above the upper limit of normal, they meet it. Creatinine clearance, or I use GFR. If it's under 60, then in my mind, they meet criteria. If they have kidney stones, sometimes you'll see us, if they really haven't met any of the other criteria, I'll order a KUB just to see if they've got, nephrocalcinosis or any calcium, anywhere along the, in the ureters, kidney stones, that type of thing. Because even if they haven't passed a symptomatic kidney stone and they have some on imaging, they've met criteria. A 24-hour urine calcium that's greater than 400 a day, that's pretty significant. And then, findings of osteoporosis or a vertebral fracture, even if the DEXA looks good. Next slide, please. And if anyone has any questions, just stop me while I'm going. So now, say the patient meets surgical criteria. I know we talked about primary hyperparathyroidism being a biochemical diagnosis, but sometimes we'll order additional imaging for the surgeons. So I'll oftentimes kind of go towards a sestamibi, which is a nuclear parathyroid scan, just to help the surgeon out. And I tell the patient, hey, this could be negative, because I feel like in my cases, the imaging is oftentimes normal. Or negative, not lighting up for any adenoma, but the patient still has an adenoma on surgical pathology once it's removed. But I just do that for the surgeon's help. There's a surgeon here, Dr. Lopinto. She oftentimes will order a 4D neck CT that will help her just kind of plot out her surgery, see if there's any, other concerning parathyroid glands. before she just goes in and does a parathyroid gland exploration, but you don't have to order any of this stuff. I've never ordered a 4D neck CT. I've just done either the ultrasound or a sestamibi scan. Next slide, please. What if they meet criteria for surgery, but they're not a good surgical candidate? So they've had, 3 strokes, their heart, they're always in the hospital with heart failure. You really don't want to send those people to surgery for this. Our only option is one medicine, Cinacalcet or Sensipar. And it basically increases the sensitivity. I know I put all this on the slide, but it increases the sensitivity of the calcium sensing receptors in the parathyroid glands. So they're a little more responsive to the high calcium, and the PTH will hopefully lower along with calcium. We usually start at a dose, depending on how hypercalcemic they are, at 30 milligrams a day, and then kind of titrate up from there. But one thing that I tell patients, if we use this, is that putting you on this medicine, it may make your labs look better, but it's not going to prevent the effects of that high PTH on the bone, which, when you have a high PTH, it's causing your gut, you pull more calcium from the foods that you eat. And you're also pulling it from the bones, which is really why we worry about it, bones and kidney stones. So it's not going to improve the effects of the high PTH on the bones, whereas surgery would. So that's something that I usually tell them. Next slide, please. So if the patient doesn't meet surgical criteria, so their calcium isn't high enough to do anything about, which we have this happen a lot. And I tell the patients, your labs look like you might be developing a problem, but it's not causing any issues yet. So it's very safe to just monitor it. Honestly, in one of our guidelines, it says just follow it every year. I am a little more aggressive, I guess. I usually repeat the labs every 6 months. I say 3. It really depends on the calcium. If the calcium is really high, I would repeat it sooner rather than later. But for these folks that their calcium's hanging around 10.5, I'll just repeat it again in 6 months, all the while warning them of symptoms of hypercalcemia, in which case they should go to the emergency room and call me so that we can check their labs sooner than that. And the labs that I usually will get every 6 months to a year is a basic metabolic panel. That way you have your calcium and your renal function, a magnesium, phosphorus, that albumin, remember, so that I can correct the calcium and make sure it looks okay. I'll repeat their parathyroid hormone level. And then based off their prior vitamin Ds, if all of their vitamin Ds in the system have been in the 40s, that's great. I'm not going to order it again. So, you go with or without the vitamin D. So that's perfectly safe to do. And you can even steer closer to that 6-month mark. Next slide, please. And then this is just kind of does anybody have any questions about PTH-mediated hypercalcemia so far? Okay, so this is just a brief note about non-PTH-mediated hypercalcemia. So, say your patient was found to be hypercalcemic, and then you went ahead and repeated the labs. You ordered a PTH, your calcium, your albumin, kidney function, everything we talked about before, and their PTH is either low. I think our low end here of the normal range is 8.5, if I recall. So say they're either below 8.5 or they're sitting at 15. I mean, that's still pretty suppressed. So I would start by getting a good supplement use history. So what are they taking in their diet? I honestly had a guy that was drinking a whole gallon of milk a day and was hypercalcemic, and we've never been able to find any other etiology of his hypercalcemia. But since I had him dial back on the milk, it's better. So he just must be more sensitive to it. If they're chewing a whole bunch of Tums because they have a lot of issues with reflux, are they taking vitamin D combined with calcium? So I usually start there. If somebody was coming in and they were found to have a high calcium and they're having night sweats and unexplained weight loss, you start to think about malignancy. So I would refer those folks sooner rather than later. One of the things that you can do while they're waiting to see us is check a TSH. So if somebody is uncontrolled hyperthyroidism, they can develop hypercalcemia. There's just, if they're hyperthyroid, all the metabolism is kind of revved up, including their bone breakdown. So they're just shooting calcium out from the bones, and that can be a cause of hypercalcemia. Before you refer them here, say it's just very mild hypercalcemia, I would just repeat it again. Make sure it wasn't just something transient. They just ate a high calcium meal a couple of days before. Repeat it and make sure that it's actually a true elevation. And then we're always happy to see these patients. I feel that I've seen tons of hypercalcemia, and I like it. It's a love-hate relationship, especially the ones in the hospital, because sometimes we don't always have an answer as to why they're hypercalcemic, but they're always good cases. Next slide, please. So what to do if the parathyroid hormone level is elevated, but the serum calcium is normal? So say you had a calcium level checked and it was high, and then you went to repeat those labs where you get them all on the same day, and now your PTH is high, but the serum calcium is normal. You should start thinking about secondary reasons why it may be elevated. So, inadequate dietary calcium. I know I mentioned this on one of the first slides about secondary hyperparathyroidism, but I'm always asking patients, have you ever had a gastric bypass or a sleeve gastrectomy? Anything where they're not going to be absorbing calcium as effectively, I kind of start thinking about, and I'll have them increase how much they're getting in their diet. If their vitamin D is low, you're going to catch that because you'll be checking the vitamin D. And then, I mentioned checking the renal function just to see if they have got chronic kidney disease or not. But that's the kind of things that you should be thinking about if your serum calcium is fine, but your parathyroid hormone level is elevated. But really, a lot of times you may not even get this, because remember, you don't really need a PTH unless you have a reason to order a PTH. So I think I mentioned, sometimes I get to talking and then I've already talked about all my other bullet points. So yeah, vitamin D, I know we talked about that. If you have a vitamin D that's low and the parathyroid hormone level is high, the calcium's fine, and you're thinking, okay, this might just be elevated because of the vitamin D being low, I would replete it. And then, 4+ months down the road, I would repeat labs to make sure it's gotten better. I usually give them a while. It can take a while to replete vitamin D stores. So I tend to steer closer to that 6-month mark than the 3-month mark. Now, if the vitamin D is greater than 30 or equal to 30, the patient doesn't have any chronic kidney disease, and the calcium's low normal. I know I kind of mentioned this already, but I'll just talk with them about foods that contain calcium. And I always tell patients that they say, should I take a calcium supplement? Well, not if you're getting enough in your diet. And honestly, the dietary calcium, so from foods that you're eating, is always going to be better than something like Tums. So, piece of cheese is a serving in my mind. So a slice of cheese. So I'll have them, have some yogurt or cottage cheese or just slices of cheese. And that will, oftentimes help. And we'll see a lot of post-bariatric surgery patients where we really have to kind of get on to them for how much calcium they may or may not be having. So next slide, please. All right. Anyone have any questions about any of that or cases?
That was great. I have thank you very much. I have a question. Can you go back again and talk about the medications, the HCTs, the SGLT2s, and lithium, and the relationship between those and calcium?
Sure. So as far as hydrochlorothiazide, I always in my mind think, and this is back from medical school, so loop diuretics like furosemide or Lasix, I always think in my mind, loops lose calcium and thiazides retain it. So loops lose calcium, thiazides retain calcium. So if you have somebody that's on a thiazide diuretic, the kidneys want to retain the calcium. So you may do a 24-hour urine collection and their calcium content is 84. And then when you're looking at it, if if we don't ask the question, then we may think, oh, if it's familial hypocalciuric hypercalcemia, we don't need to do anything. But in reality, we didn't get that history from that they're on the thiazide diuretic, and that can kind of skew results. So I actually have a couple people that I'm having them hold that component of their hypertensive regimen for just 2 weeks. I'm just having them hold it for a couple weeks and then repeat those tests. And then after they repeat the urine, the 24-hour urine collection, and then after they repeat it, then I'll have them restart it. It's not bad to take, it just might skew that result for you. The SGLT2 inhibitors, those can make the calcium potentially, just because they're urinating a lot, I just wouldn't trust the result. I think I had a patient that's calcium looked low, but I think they can also look high too. But just because you're, trying to push out glucose into the urine, you might be urinating more and the volume might be higher. So your calcium may be a little more dilute. So that can affect things. And then lithium can cause just different problems at the kidney. And so, that can, if they're on it, that would be a tough one. I've not had that situation happen where I've had, because that's, if somebody's on lithium, they're usually on it for a while and they need it. And I'm always hesitant to stop those things. So I think that would just be kind of a case decision where we'd have to, maybe check their 24-hour urine calcium and see. There's also lithium-induced primary hyperparathyroidism. I saw a patient the other day that had that in their history. And so, in that case, I think it's just labs will help you, but the urine, I don't know. Have you had this happen? Yeah, I haven't seen a lot of patients that are on lithium. So I think it would just have to be kind of a case-based decision. Does that answer your question?
Yeah, that was great. Thank you. And I have one more question. I'm rushing a little bit because I can hear my patients here, but with Sensipar, so if you keep them on Sensipar, do you do a bone density?
You can. Yeah, that should be fine to do. I'm sorry, did you say can you do a bone density?
I think I said should you do?
Oh, I would, just as normal screening. If you're doing a bone density on somebody just for routine maintenance and you think they might have primary hyperparathyroidism, one thing that I would say is I put in the comments when I order them to please include a forearm measurement.
Oh.
And so you could do that for those patients that you have on it. I would just as monitoring too. If they have primary hyperparathyroidism, it's going to be pulling calcium from the bones and they may be at a higher risk of developing some osteoporosis down the road. But yeah, so primary hyperparathyroidism, for some reason that PTH really likes the forearm. And so, I've had patients where they have biochemically confirmed primary hyperparathyroidism and their forearm score might be -2.3 and the rest are -1. And so, it'll be a pretty big discrepancy, but yeah, I would probably just as normal routine monitoring.
Thank you so much.
Thank you.
That was a wonderful presentation. Thank you so much, Dr. Turner. You did a great job.
Thank you.
Does anybody else have any comments or questions they would like to have? We have about 5 minutes left before final announcements and a poll. It's voluntary, but please do take the time to do it. It's pretty quick. All right. Okay, so our next session will be September 22nd with Renee Schwartzweger discussing goiter management. I'll pop up that poll and